Welcome to the deep dive. Today we are plunging into, the absolute bedrock of medical surgical nursing.
Really are.
The body's magnificent yet precarious relationship with stress, adaptation, and injury.
Right.
You've provided us with comprehensive material straight from a core nursing text, and our mission today is to turn this foundational knowledge into, real clinical wisdom.
That's exactly right. For anyone needing to master how the human body maintains its internal constancy, how it fights back when its steady state is threatened, this deep dive is your shortcut.
And we aren't just memorizing definitions here.
No, not at all. We are tracing the functional and structural changes, from the cellular level all the way up to comprehensive family care to really understand what makes a response truly adaptive
Leading to health.
versus maladaptive, which leads directly to disease.
We'll cover the whole landscape. The lightning-fast fight-or-flight mechanism, the lingering effects of stress hormones, cellular injury, inflammation, and maybe most importantly, the evidence-based nursing interventions we use to promote resilience and healing. We're following the textbook's logic exactly, making sure you can really visualize these interconnected systems in action.
And we begin at the beginning with the fundamentals that ensure our internal environment remains in that dynamic balance.
Okay, so when we talk about life itself, we have to start with this concept of internal stability. It originated way back in the 19th century with Claude Bernard, the French physiologist.
Right.
He coined the principle of constancy, or the fixity of the internal milieu. What exactly did he mean by that internal milieu?
He was talking about the fluid that bathes all the cells, basically the entire environment inside the body.
Okay.
He recognized that for an organism to survive and, thrive, its internal state had to remain stable, kind of protected from all the chaotic changes of the outside world.
So constancy just means maintaining that balance.
Yes, through ceaseless biochemical and physiologic processes. It was a groundbreaking idea, but Bernard's original concept was a little static. It implied a fixed state.
And that's where the concept evolved, right? Because the internal environment isn't fixed at all. It's always moving and adjusting.
Exactly. And that leads us directly to homeostasis, the dynamic, steady state within the body. It's not a single fixed temperature or blood pressure. It's a stable range.
So when a change happens, a stressor.
It triggers immediate restorative feedback processes that are all designed to bring the system back into that narrow functional range.
Can you give us a quick example of a body system, succeeding at that?
Oh, a classic one is intense exercise. You create an oxygen debt, you produce lactic acid.
Right.
The body immediately senses this deviation. It compensates with hypertrophy, that's rapid deep breathing, to restore oxygen and normalize the acid level. That's a perfectly executed successful move toward dynamic balance.
But the clinical danger, especially in med-surg, is when those compensatory mechanisms are either inadequate or, even worse, they're counterproductive.
Precisely. If that compensatory mechanism fails or it becomes misdirected, the steady state is threatened. And that often results in disease and abnormal structure or function.
Like with heart failure.
A perfect, if tragic, example. The body senses dangerously low cardiac output. It tries to compensate by releasing hormones that cause the kidneys to retain sodium and water.
Which would be great if you were hemorrhaging.
Exactly. But in this case, that fluid retention actually increases the volume the failing heart must pump. It actively worsens the heart failure. It's an adaptive mechanism gone rogue.
Wow. So that really highlights why we have to visualize the body as a whole.
Yes. If you think of the body as this interconnected web, a huge constellation of systems, you see the cell as the smallest system. And all systems are working tirelessly toward that dynamic balance. If one subsystem fails, it impacts the constancy of the whole organism.
Okay, so once we get the goal dynamic balance, we can define the thing that disrupts it.
The disruptor. Stress. It's the condition caused by an environmental change that is perceived as challenging, threatening, or damaging.
And the key word there is perceived.
It's everything. The central component is the perception that the person feels unable to meet the demands of the situation.
And the thing that causes that condition is the stressor, the stimulus, internal or external, that provokes all those changes.
Right. Physiologic, emotional, cognitive, behavioral changes.
So if stress is the condition, the goal after facing it is adaptation? or coping.
Yes, that's the adjustment process, using cognitive and behavioral strategies to get back to equilibrium.
And this isn't just about one person. This scales up and down.
Oh, the scale is huge. Stress and adaptation are studied not just in the individual, but also at the cellular level, the tissue level, the organ level, and then it extends all the way up to the family and to society.
But the goals are always the same.
Fundamentally, yes. Survival, growth, and reproduction.
So stressors are not monolithic. As nurses, we need a refined way to categorize the input to understand the impact. How do we start to break them down?
First, by type. We have physical stressors, cold, heat, chemical agents. Then physiologic stressors like pain, fatigue, or an infection.
And then the big one, psychosocial stressors.
Right. Fear of failure, job insecurity, the anxiety you feel before a big diagnostic test. We also have to remember that even normal life transitions, like marriage or puberty, are still stressors because they demand a massive internal adjustment.
And the second classification, by occurrence, this is where that crucial non-intuitive insight about health comes in.
It really is.
We have the major complex occurrences, war, terrorism, rapid tech change, and those cause large-scale tension. We also have the relatively infrequent events like a death, a divorce, or chronic caregiving. But the category that consistently packs the biggest punch, it's the day-to-day hassles.
That's the key takeaway right there, and it often surprises people. The textbook really emphasizes that the daily hassles, traffic jams, your computer crashing, chronic low-grade arguments, they have a greater cumulative health impact than a single major life event.
Wait, why is that? Why does constant low-level irritation matter more than a huge, devastating one-time event?
It's because of the cumulative effect. A major trauma triggers that acute alarm phase, followed by resistance and then hopefully recovery.
Okay.
But daily hassles, they keep the body locked in the resistance phase, a state of chronic low-level arousal. This sustained stress continuously secretes hormones that tax the system.
It's just constant wear and tear.
Exactly. And that can lead to chronic issues like essential hypertension or persistent palpitations. It's the disease of 1,000 cuts.
That makes perfect sense. The system never gets to truly rest or return to baseline. And we also categorize by duration. Acute, like studying for an exam, a stressor sequence where one thing leads to another.
Like job loss triggering financial stress, which triggers relationship problems.
And then chronic intermittent, which are those daily hassles, and chronic enduring, like a lifetime of chronic illness or poverty. Recognizing that duration helps us gauge the patient's allostatic load.
Their accumulated wear and tear, yes. The research linking chronic, unrelenting stress to disease is overwhelming. So when we treat stress as a stimulus, we need validated tools to measure this input and predict the potential risk for illness.
The classic starting point is the life event scales, like the one from Holmes and Rahi back in the 60s, and its successor, the Recent Life Changes Questionnaire.
The RLCQ, right. These tools assign a numerical value, a life change unit to events, both good and bad.
So marriage gets points, but so does a loss.
Exactly. And the premise is that the total accumulated units predict the likelihood of illness because adaptation takes energy.
But modern tools have evolved past just counting events.
They have. Tools like the SOS, the stress overload scale, and the stressometer. They incorporate the subjective experience, the person's vulnerabilities. They understand that external stressors interact with internal characteristics, like your relationship quality.
So it's not just what happens to you.
It's how equipped you are to handle it.
So when a nurse walks into a patient's room, what are the most common sources of distress that signal this impending imbalance?
They so often center on loss, alterations in physical or emotional health, decreased social support, or losing a significant other. We hear a lot of fears, too.
Fear of what, specifically?
Immobilization, isolation, loneliness, sensory changes, financial strain, and of course, fear of death or disability.
And a crucial, often overlooked source of distress is the loss of one's role or purpose.
Yes, especially in chronic illness or retirement. And if a patient's coping mechanism is already ineffective, say, they deny their illness or rely on substance use, that lack of coping becomes an additional self-perpetuating source of distress.
And that's a direct pathway to stress-related illness.
It is. Identifying that dysfunctional pattern is where nursing intervention truly begins.
So once a stressor hits, the person doesn't just launch into a physical response. There's a vital mediating process in the middle.
Yes, cognitive appraisal and coping. This process essentially dictates the intensity and duration of the physical mobilization.
And the Lazarus theory of cognitive appraisal breaks this down into two steps. What's the first step?
Primary appraisal. It's the immediate check. What is at stake here? Is this non-stressful, or is it a threat, a loss, or a challenge?
And that's influenced by your own goals and identity.
Profoundly. If the appraisal is harm or loss, you get negative emotions, fear, anger. If the appraisal is a challenge, positive emotions kick in. I can handle this.
And then the brain moves to secondary appraisal. Okay, what might and can I do about this? That's the strategy part.
Right, followed by reappraisal if new information comes to light.
So it sounds like we're saying a patient's personality dictates their health outcome. Is that really fair? Or we're just saying resilience is a learned skill?
Oh, it's absolutely a learned skill. It's all about coping, the cognitive and behavioral efforts we use to manage demands. And we teach patients how to effectively use two main types.
Okay, what are they?
Emotion-focused coping, which seeks to lessen the emotional distress, things like journaling, seeking support, or positive self-talk.
And the other is more action-oriented.
Exactly. Problem-focused coping, which aims to make direct, tangible changes, like enrolling in a job training course after being laid off. And both types usually happen at the same time.
So if appraisal and coping are influenced by these internal characteristics, the nurse's job is to enhance those characteristics. We focus on two key areas. First, health-promoting lifestyles.
Yes. Eating well, sleeping, exercising, they are crucial buffers. It's often much easier and more effective to promote these healthy habits than it is to remove the stressors themselves.
And the second area is resilience.
The ability to maintain functioning and recover quickly after trauma or stress. A resilient person is flexible. They maintain control over strong emotional reactions by communicating them appropriately, and they use effective problem-solving skills.
They know how to nurture themselves.
They do. And research shows resilience is a powerful variable that directly correlates with positive recovery outcomes.
Okay, now we make that sharp transition from the psychological filter back to the hard physiology. We're talking about Selye's Foundational General Adaptation Syndrome, or GAS.
The GAS provides the map for the systemic response to any stressor. Phase 1 is the alarm stage,
The initial shock.
the instantaneous shock. The sympathetic nervous system activates the fight-or-flight response, triggering the release of catecholamines and the adrenal cortical response. It's defensive, but it can only last for so long.
If the stressor persists, we enter resistance.
The body tries to adapt. Cortisol activity is still increased, but the body stabilizes at a new, higher level of functioning. But this is draining your reserves.
And if that stress is relentless, the organism hits exhaustion.
Yes. Prolonged endocrine activity leads to negative, debilitating effects on body systems, digestive, immune, circulatory. This cumulative wear and tear can, in extreme cases, lead to death.
Selye also recognized the local adaptation syndrome, the LAS.
Right, which is the body's localized response, most notably the inflammatory response and repair at a specific tissue site, like a simple cut.
But a major local injury, say a severe burn, that's going to activate the whole system.
Absolutely, that will activate the full systemic GAS. And the most important takeaway from Selye is that stress itself is a nonspecific response common to all stressors.
So why do two people exposed to the same trauma have such wildly different outcomes?
It's due to conditioning factors, genetics, environment, pre-existing health. These factors determine who develops the diseases of adaptation and who remains relatively unaffected.
The GAS gives us the big picture, but the brain is the GPS, coordinating this massive physiological mobilization. Where is the command center?
That's the hypothalamus. It's centrally located and acts as the master coordinator. Its job is to integrate the autonomic nervous system mechanisms and make all the adjustments necessary to maintain homeostasis.
And it doesn't work alone.
No, it interacts with the limbic system for emotional and visceral control. Those base behaviors like defense and aggression, and the cerebral hemispheres for high-level cognitive functions like learning and memory.
So how does the signal flow?
Well, the afferent impulses, sensory information, and internal sensor data, they travel up to the brain. The hypothalamus integrates this perception of a threat, and the response follows a strict, sequential timing.
What comes first?
First, the rapid sympathetic nervous system discharge, then the sustained sympathetic-adrenal-medullary discharge, and finally, if the stress persists, the long-acting hyperthalamic-pituitary system is recruited.
Let's detail that rapid, short-lived defense mechanism, the core of the alarm stage. The body is preparing for immediate action.
The sympathetic nervous system response is instantaneous, mediated by norepinephrine. This rapidly increases the function of vital organs and ramps up general arousal.
So we see an immediate increase in heart rate.
and peripheral vasoconstriction, which forcefully raises blood pressure. And crucially, blood is shunted away from non-essential organs, the gut, the skin, and directed to the brain, the heart, and the skeletal muscles.
You can see this clinically right away. If I walk into a patient's room and they are extremely anxious or in acute pain, their feet are cold, their hands are clammy, they might have a knot in their stomach.
And their respirations are rapid and shallow. That is the sympathetic system prioritizing survival by shunting blood flow.
And the second part, the sympathetic-adrenal-medullary response that sustains this high alert state.
It does. Sympathetic stimulation signals the adrenal medulla to flood the bloodstream with catecholamines, epinephrine, and norepinephrine. This hormonal release prolongs the nervous system's actions, keeping the body primed.
Let's look at the specific coordinated effects of this. Imagine a patient has a massive internal hemorrhage. The body launches this response to protect itself.
Okay, so the body demands energy and perfusion. First, heart rate and blood pressure soar. The purpose is to maximize perfusion to the brain and muscles.
And the mechanism is just increased cardiac output and that vasoconstriction.
Exactly. Next, blood glucose spikes. Purpose: immediate fuel. Mechanism: rapid breakdown of liver glycogen and triglycerides from fat tissue.
And what about the mental effects?
Mental acuity sharpens. You get increased awareness, rapid decision-making, that's from increased blood flow to the brain, and pupils dilate.
And then there are the protective measures. Skeletal muscle tension increases.
To prepare you for running or fighting.
Right. And blood coagulability increases.
Which is to prevent catastrophic blood loss if trauma occurs. This entire mechanism is just a marvel of evolutionary orchestration focused entirely on survival in the immediate moment.
While fight or flight handles the immediate threat, persistent stress, that resistance phase, requires a sustained energy source.
And that's governed by the longer-acting hypothalamic-pituitary pathway.
Okay, walk us through that cascade, starting with the hypothalamus.
The hypothalamus releases corticotropin-releasing factor, which travels to the anterior pituitary. The anterior pituitary then releases ACTH, which signals the adrenal cortex.
And the adrenal cortex produces powerful corticosteroids, principally cortisol.
Cortisol is the key metabolic hormone of chronic stress. It's all about mobilization and storage management.
What are its major effects?
It stimulates protein catabolism, essentially breaking down body protein to release amino acids. It then drives the liver to convert those amino acids into new glucose. That's gluconeogenesis.
And crucially, it has a significant anti-insulin action.
Yes, it inhibits the uptake of glucose by most body cells so that the brain and heart have preferential access to fuel.
This has a massive, immediate clinical implication, doesn't it? If cortisol is anti-insulin, a patient who's already diabetic and is suddenly under acute stress, like a major infection or surgery, is fighting a losing battle with their glucose control.
That's right. It is a critical nursing principle. A diabetic patient under stress will require significantly more insulin than usual.
Just because their own body is working against it.
Yes. And moreover, any patient under prolonged stress, regardless of their diabetes status, is catabolizing body protein. This leads to protein wasting, impaired wound healing, and a need for nutritional supplements.
What other key hormones are operating in this persistent stress environment?
We see ADH, antidiuretic hormone, and aldosterone released. They are fluid conservers, promoting sodium and water retention.
Which is highly adaptive if the patient is losing fluid from, say, a hemorrhage.
Exactly. ADH also contributes to vessel constriction, raising blood pressure, and some studies suggest it even facilitates learning and coping processes, potentially helping the person adapt.
And we can't forget the internal painkillers.
The endorphins. These endogenous opioids increase during stress, significantly raising the threshold for pain tolerance.
Which makes sense from a survival perspective. You need to keep fighting or running even if you're injured.
Right. They also contribute to mood changes, like that temporary feeling of euphoria we call the runner's high.
We've established that the nervous and endocrine systems are fully mobilized. But how does that affect the third pillar of internal defense, the immune system?
The connection is profound. Lymphoid tissues, where immune responses are mounted, are richly supplied by autonomic nerves. The neuroendocrine hormones we just discussed, like cortisol and catecholamines, they directly inhibit or stimulate leukocyte function. The systems are fundamentally intertwined.
And the discipline that studies these complex relationships is psychoneuroimmunology, or PNI.
Right. P&I studies the relationships among the nervous, endocrine, and immune systems and how their collaboration affects health outcomes.
So the subjective experience translates into a measurable biological reality.
Exactly. Because the brain mediates the initial perception of stress and coping styles determine the duration and intensity of the response, P&I shows us definitively that a person's thoughts and emotions can have direct neurochemical and immunologic consequences.
We see this in studies.
Oh, absolutely. We see documented altered immune function suppression in people under chronic stress, and conversely, positive personality traits like conscientiousness and compassion have been statistically linked to positive health effects. P&I aims to uncover the pathways by which we can consciously influence our own immunity.
Reinforcing the idea that mind and body are just inseparable in health and disease.
Yes.
So we've explored the body's protective responses. But when these responses become chronic, excessive, or inappropriately channeled, they become maladaptive.
They cease to promote the goals of adaptation, which are physical health, psychological well-being, and positive social functioning.
And maladaptive responses often start with faulty appraisal.
Or inappropriate coping, such as using denial, alcohol, or illicit drugs, which dramatically increases the risk of illness.
A non-substance example that immediately comes to mind is the classic type A behavior pattern.
Correct. Chronic impatience, competitiveness, aggressive behaviors, they're all associated with elevated chronic catecholamine output. The person is essentially locked into a permanent low-level fight-or-flight state.
And that chronic arousal is the mechanism that leads directly to disease. A prolonged sympathetic-adrenal-medullary response means chronic high blood pressure, vascular constriction,
which can accelerate arteriosclerotic changes, dramatically increasing the risk of cardiovascular disease.
And if the prolonged stress involves the hypothalamic-pituitary axis with chronic ACTH and cortisol,
you can see psychological withdrawal and depression. And physiologically, the immunosuppressive effects of cortisol mean a decreased immune response, leading to an increased susceptibility to chronic infections and certain types of tumors.
Selye termed these conditions the diseases of maladaptation. The point is clear. When the body's defense mechanisms are chronically overactivated, they become the agents of destruction.
And given that devastating potential, nurses must be highly skilled in assessing and recognizing the indicators. We're looking for subjective symptoms and objective signs across physiological and behavioral domains.
Let's group some of the key physiologic signs we should be vigilant for.
Okay, in the musculoskeletal system, look for chronic muscle tension, especially in the neck and shoulders, and bruxism, that's teeth grinding.
Cardiovascular signs would be headaches and palpitations.
Very common. And gastrointestinal distress is huge. Nausea, vomiting, diarrhea, or constipation. Systemic signs include generalized fatigue, excessive perspiration, and tremors. These are all echoes of that sympathetic hyperarousal.
On the psychological and behavioral side, the signs are often disruptive. Increased anxiety, emotional ability, nervous laughter, and severe concentration difficulties are major red flags.
And behavioral changes often involve poor self-soothing strategies, like increased consumption of tobacco, alcohol, or illicit substances. Other indicators include impulsive behavior, hyperactivity, a strong startle response, and that profound loss of interest in life anhedonia.
In addition to these observable signs, we use lab analysis to objectively quantify the stress load. What are the key chemical measures?
We rely on blood and urine analysis for hormonal shifts. Catecholamines, corticosteroids like cortisol, and ACTH levels are reliable stress measures. We also look at eosinophil levels, which are decreased in acute stress, and elevated serum cholesterol and free fatty acids.
Because the adrenal hormones can actually raise cholesterol.
Yes, another direct pathway linking chronic distress to cardiovascular risk.
Okay, let's shift now to the microscopic unit. If we visualize the cell, it exists on a precarious continuum.
It does. It's either normal, adapting, injured, diseased, or dead. And the earliest changes, long before a patient feels symptomatic, they occur at the molecular level.
And the fate of the cell depends on its ability to adapt. Its type cardiac muscle succumbs to hypoxia much faster than smooth muscle, and the duration and intensity of the stimulus. How does the cell maintain its steady state?
The cell's steady state, like the body's, is governed primarily by negative feedback. Think of it like a home heating system.
The thermostat is the detector.
Exactly. When the temperature drops, a deviation, the system triggers the furnace, a response, to offset the drop. Once restored, the response stops. It's a self-correcting loop.
And in the body, that regulates everything from acid-base balance and blood pressure to temperature. Give us a physiologic example.
Carbon dioxide regulation. If CO2 increases in the extracellular fluid, chemoreceptors in the brainstem detect this. They signal the respiratory center to increase the breathing rate
which exhales the excess CO2.
and normalizes the pH, which then stops the signal. Perfect negative feedback.
We should also mention positive feedback. It usually leads to disorder, but there are beneficial exceptions.
Right, like the rapid acceleration of the blood clotting cascade or the hormonal cascade during labor. But generally, it pushes the system toward instability.
So when cells face chronic environmental stress, they don't just sit there, they adapt structurally. And these 5 adaptations are crucial diagnostic signs.
Yes, they show how the environment is influencing tissue health.
Okay, first, atrophy. This is the cell and organ decreasing in size.
Right, caused by decreased use, decreased blood supply, or disease. We see this in skeletal muscle after a long period of immobilization.
Second, hypertrophy, an increase in cell size.
This is often an adaptive, compensatory response to a prolonged increased workload. The ventricular muscle in a hypertensive patient, for example, increases in size to generate more force.
Third is hyperplasia. This is an increase in the number of new cells.
And it's reversible if the stimulus is removed. This is often hormonally induced, like the thyroid gland enlarging due to increased TSH.
Fourth is metaplasia. This is a conversion. One mature cell type converts into another, usually for a protective advantage.
A classic example is in the bronchi of a heavy smoker. The ciliated columnar epithelium gets replaced by tougher, more resistant squamous epithelium. The cells survive the smoke,
But the protective function of the cilia mucus is completely lost.
which is damaging long-term.
Exactly.
And fifth, the most concerning, is dysplasia. This is bizarre growth where cells differ significantly in their size, shape, and overall arrangement. Dysplastic cells have a tendency to become malignant. It's a significant step toward disease.
Cellular injury is any disorder in steady-state regulation that leads to structural or functional damage. Identifying the cause is paramount.
Because an injured system is highly vulnerable to secondary injuries.
The most prevalent cause is hypoxia, oxygen deficiency, which interferes with the cell's ability to generate energy. And the most common cause of that is ischemia.
Deficient blood supply, often from atherosclerosis or clots. We have to remember the time factor. Brain cells are extremely vulnerable, often succumbing within 3 to 6 minutes of total ischemia,
Next is nutritional imbalance.
which can be deficiency or excess. Undernutrition leads to wasting, but overnutrition obesity is equally damaging. It overloads cells with lipids and causes chronic metabolic strain.
We also have to address physical agents, extreme temperatures.
Hyperthemia above 41 degrees C or 106 degrees R causes cell protein coagulation. Extreme cold causes vasoconstriction, clot formation, and even ice crystal formation that can burst cells.
Then there's radiation, electrical shock, and mechanical trauma.
Right. And chemical agents are widespread. External poisons like lye or internal imbalances like excessive stomach acid. We see high rates of drug toxicity, especially in older patients due to polypharmacy.
And of course, the toxicity of ethanol.
Yes, its breakdown product, acetaldehyde, is directly toxic to liver cells, initiating the cycle that leads to cirrhosis.
And rounding out the causes are infectious agents, disordered immune responses, and genetic disorders.
A whole host of potential insults.
So once injury occurs, the body activates its protective first responder, inflammation. This is a localized, non-specific reaction, and this is a critical distinction for nurses.
It is. Inflammation is a response, and it is not the same as infection, though infection is a frequent cause.
And the response manifests as the 5 cardinal signs: redness, warmth, swelling, pain, and loss of function. If we trace the sequence, how do these signs appear?
First, a transient vasoconstriction, immediately followed by significant vasodilation. This rush of blood to the area causes the warmth and redness.
Next, the microvasculature increases its permeability.
So plasma fluids, proteins, and solutes leak out of the vessels and into the tissue space. This fluid accumulation causes the hallmark sign of swelling or edema.
Then the leukocytes, our immune cells, migrate to the site for phagocytosis.
They engulf debris and pathogens, and fibrinogen in the leaked fluid coagulates into fibrin, leading to clot formation, which walls off the injured area.
The pain results from the pressure of the swelling and irritation from chemical mediators like bradykinin.
And the final sign, loss of function, is a protective reflex caused by the pain and swelling, forcing the person to rest the injured part.
And this whole sequence is orchestrated by chemical messengers.
Yes. Histamine from mast cells is responsible for the immediate vasodilation and increased permeability. Kinins amplify that and attract immune cells, and prostaglandins sustain the increased permeability.
While inflammation is local, it often causes systemic responses. What are the key body-wide indicators?
The most common is fever. This is caused by endogenous pyrogens released by immune cells that travel to the brain and literally reset the hypothalamic thermostat to a higher temperature.
We also see leukocytosis.
An increased production and release of neutrophils from the bone marrow. The patient will also feel general, non-specific symptoms like malaise, loss of appetite, and aching.
We categorize inflammation by duration. Acute inflammation is protective and usually resolves within 2 weeks.
But chronic inflammation is debilitating. It persists for months or years. It's destructive, involving a cycle of cellular infiltration, necrosis, and fibrosis, almost always resulting in permanent tissue damage and scarring.
Once a cleanup phase is complete, healing begins. The body attempts 2 main types of repair.
Regeneration and replacement. Regeneration is the optimal outcome repair by proliferation of the same cell type, restoring normal function.
And that depends on the cell's ability to multiply.
It does. Labile cells like skin and GI tract lining multiply constantly and regenerate easily. Permanent cells like neurons cannot regenerate. And stable cells from the liver, kidney, pancreas have a latent ability to regenerate if damaged.
When regeneration is impossible, we get replacement.
Connective tissue fills the defect, resulting in scar formation and an irreversible loss of specialized function.
Healing is also categorized by intention. Primary intention is for a clean surgical incision.
Right. The edges are approximated, minimal scarring, heals quickly. Secondary intention occurs with significant tissue loss, where the edges can't be approximated. The wound has to fill with slow, extensive granulation tissue,
resulting in a large scar and loss of function.
Exactly. Think of the fibrotic scar tissue after a major heart attack. That scar cannot conduct electrical signals, which fundamentally alters heart function forever.
So, because stress is ubiquitous, the nurse's role is to identify these maladaptive responses early, ideally intervening while the patient's compensatory mechanisms are still functional.
Our assessment has to be holistic, linking subjective symptoms to objective data. We review vitals, check for deviations, look for affective or cognitive problems, and specific physical signs.
Objective evidence from labs and diagnostics helps us quantify the disruption. Once assessed, the nurse translates these human responses into relevant nursing diagnoses.
Right. Key diagnoses often include anxiety, difficulty coping, or denial. Others might be social isolation, risk for spiritual distress, or lack of resilience. An accurate diagnosis is the foundation for targeted, effective interventions.
And the ultimate goal of nursing management is reducing and controlling stress, preventing illness, and promoting health by building the patient's resources.
A powerful initial step is using the Health Risk Appraisal, or HRA. This assessment method identifies specific risk factors and recommends precise changes, like a smoking cessation program.
And that questionnaire is incredibly comprehensive. It covers demographics, family history, lifestyle choices, stressors at home and work, social support,
and objective physical measurements like BMI and lab work.
And here is where we find a truly critical insight from HRA research, one that speaks volumes about public health priorities.
It's a huge one.
Research indicates that the single most important factor determining health status is social class. And within a social class, the major factor influencing health is the level of education.
That is a profound finding. It means that while we focus on the physiological response, we cannot ignore the societal context. Our teaching interventions must be adjusted based on the patient's educational background and socioeconomic resources.
Absolutely. So moving to direct intervention, the Nursing Interventions Classification, or NIC, defines coping enhancement as facilitating cognitive and behavioral efforts to manage stressors. The nurse plays an active role here.
We do. This includes assisting the patient in setting realistic goals, solving problems constructively, and providing clear information. We encourage realistic hope and foster constructive outlets for anger, helping the patient appraise their resources and identify support systems.
We also build on the patient's existing strengths.
Yes. When facing illness, patients commonly cope in 5 ways: maintaining optimism, using social support, drawing on spiritual resources, trying to maintain control, and trying to accept the situation. We reinforce those intrinsic adaptive patterns.
One of the most tangible, evidence-based strategies we offer is teaching relaxation techniques. These methods cause the hypothalamus to adjust and dramatically decrease sympathetic activity.
And it's vital to stress that this is a learned response. It requires practice. All effective techniques share 4 core elements: a quiet environment, a comfortable position, a passive attitude, and a mental device.
Let's discuss two specific techniques. First, progressive muscle relaxation.
This involves sequentially tensing and releasing various muscle groups from head to toe, focusing intensely on the difference between the feeling of tension and the feeling of deep release.
And second, the foundational technique from Dr. Herbert Benson, the Benson relaxation response.
Right, and the philosophy is simple. First, choose a focus, a phrase, a prayer, a word that anchors you. Second, synchronize that focus with your breathing. And third, and this is the most difficult part, maintain a passive attitude towards distraction.
Just let the thoughts come and go.
Exactly. Acknowledge the thought without judgment and just return to your focus phrase. The power of these techniques lies in their ability to interrupt that chronic stress circuit.
We also use guided imagery, where the patient mindfully uses a pleasant scene, like a tropical beach, immersing all senses to distract themselves or mentally recharge.
And providing thorough preparatory education is an often underestimated nursing intervention. Giving patients sensory and procedural information shifts their perception from a threatening unknown to a manageable challenge.
We must remember to tailor this education for specific populations, too. Studies have shown a concerning disparity, where women service members and veterans often receive less critical health education.
So nurses must be keenly attuned to their unique educational needs, providing targeted resources. And the family is central to a person's steady state. We must intervene with the entire family unit.
Because their coping style directly impacts the patient's recovery.
It does. Maladaptive family coping denial, withdrawal, substance abuse can perpetuate conflict and worsen the patient's illness.
And finally, social support is a potent moderator of life stress.
It provides crucial emotional information. This support comes in three forms: emotional support, feeling cared for and loved; esteem support, feeling valued; and network support, feeling part of a mutual obligation system, which provides access to practical aid.
And the quality of this support matters immensely. It needs deep involvement and trust, not just frequent interaction.
Exactly. This is why we often recommend support groups. They provide both esteem and network support.
And this is particularly crucial for veterans.
Yes, who often lose that innate network of the military community. Group psychotherapy has proven highly effective in reducing PTSD symptoms, primarily by rebuilding that essential social support structure among peers.
So we have covered the entire cycle, from Claude Bernard's constancy to Selye's massive physiological mobilization, and from cellular adaptation down to the crucial role of nursing intervention via tools like the HRA, coping enhancement, and relaxation.
It all comes back to balance. The body is always striving for balance, even under immense pressure.
The clinical takeaway is that stress and disease are fluid points on a continuum.
And we possess the physiological knowledge and the evidence-based psychosocial strategies to intervene powerfully. Our greatest impact comes from identifying distress early and teaching patients to leverage their internal resource resilience and their external resource social support
To promote functional healing and positive health patterns. Consider this as you move forward with your clinical practice. If resilience hinges on flexibility and controlling strong emotional reactions using appropriate communication, what small, intentional shift in your personal communication style this week could best serve to maintain your own vital, dynamic, steady state? Keep applying these concepts.
Thank you for joining us for this deep dive into stress, adaptation, and inflammation.